flag. I pledge
Allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. Before we go much further, would you introduce our new employee?
Yes, we have here Juanita Trinkle, and Juanita is our clinic's manager, director, manager, I'm not sure. Director.
Last
So-
name again?
Trinkle.
It's like twinkle, twinkle, little star.
Yes, very much, exactly.
T-R-E-N-K-L-E, watch for it on the football field.
Yes.
Trinkle.
Football
Thanks,
player.
Tom.
Welcome.
Yes, welcome aboard.
Yeah, I'm glad to be here.
We expect great things.
No pressure.
Yeah.
We're going to open up immediately to public comment. I don't see any public other than our reporter, but got anything you want to say?
Good.
They're good? Okay. So we'll move on. I understand we have a video.
Yes, we have two videos. I think I sent a note to all of you that we were very, very fortunate that, well, two things to say. First off, every year, the Office of Rural Health holds a competition, if you will. They look for a rural health hero, and that's someone who has had a big impact on the community, and they've been selected from all over. This year, we're very fortunate that Bobby Steninger was the person selected. They also hold a fundraiser, and that is to, at this Office of Rural, or the Rural Health Conference every year, to raise money for EMT volunteers throughout Oregon to help in their training. So we have two videos we'd like to show you. The first one is the video about the EMT training, and the second is on specifically Bob. But they did the filming here in Lakeview, so we can run those. Please. The Apple a Day campaign is the
So
one.
the Apple a Day grant, I first heard about it after I'd been a volunteer for the disaster short time, and they were talking about doing a basic EMT class, something I never thought I'd be interested in, but once you get into EMS, you want to help people more and more and more. So I was very interested in doing it, and I was excited about it, but didn't have financial means to do it. I heard from our EMS support that we had this opportunity to apply for this grant, which would cover books and some extra costs for the class, and I was actually able to take the class in my EMT basic because of the Apple a Day grant.
My husband and I both are registered with the National Registry, and so that requires us to have 72 hours of continuing education every 2 years. And that really is a lot, even when you're retired. And so, and basically here within Lakeview, we've got our monthly meetings, but other than that, it's pretty difficult to find those hours, those accredited hours.
I know that we've gotten some grants and we put it to good use because they really help with our training. Training is very big here because we have quite a bit of turnover. Plus, if we can get the training in-house, it saves a lot of drive time and travel time and cost.
It is by far 100% needed, wanted, have to have that availability of those funds. Other rural communities, I would guess, are exactly the same as we are. We can't further our education. For a while, we didn't have hardly any basics. We had no intermediate. And the hospital staff that we did have, obviously, they're on call at the hospital, they're physicians, they're nurses, whatever. They have other priorities. So without that grant, we wouldn't have been able to get the basics through that we did and be able to further our education, to be able to offer a better line of service to our clients and customers that need us.
Anything that the state or anybody can help us with the cost really helps us to continue to get our education.
But there's people on this unit, I think, that could very well use a grant like that at least once a year. You know, if the unit doesn't have the money or they want to go to a special conference and
anytime that we can get a help with our budget, you know, it makes a big difference, you know, and either we gotta give up something else to get the training, or we can, if we can get the training, maybe we can buy some extra equipment.
I believe that everyone in our unit, and we're not, I know we're not alone, needs the additional funds to help us get our continuing education credits.
Volunteers are what hold it together. Without volunteers, we wouldn't have EMS in this community. We wouldn't be able to help our community, everyone that needs the help. There would be nobody to respond. So we are solely 100% reliant on our volunteers.
So every year, this Apple a Day program raises money, and they raised $13,500.
What was the award that went through that, how much?
I don't know exactly. I think it's based on the number of people that apply, but that's how much money was raised through this program. So the second is the video that was done specifically for the rural Oregon hero. And that's Bobby Stinch.
Every season is beautiful. You know, the people are what makes things tick here. The volunteerism, volunteer fire department, volunteer EMS, volunteer search and rescue.
Very rural, 100 miles from anywhere, so you get used to traveling a lot.
If you don't love it or don't like to do it, you won't do it. And we have this program with Bobby that has her class down there, this EMR class, and she does all the training down there, so we give you credit for it. And then we provide an avenue for them to get hands-on.
I love my students. When you're here as long as I've been here, you get an opportunity to see them grow up, become adults and have their own kids. I taught a lot of people's kids and their kids. And the people here that I work with are dedicated. They're people who care and they work hard.
She's a huge asset to us and a huge asset to those kids, and I think one of the best programs in the state that has been going for years now.
Nice thing about Bobby, she has a class, she incorporates stuff, and she kind of weeds out the ones that might be a good memory. You know, the other thing is they've got the basic training, so when you get started, they can hit the ground running.
And she's not going to ask you to do anything that she wouldn't do. I mean, she gets up and, you know, she feeds cows, she waters cows, she fixes fence.
Well, I ranch, teach, coach, do what I can for the EMS. I get up at 4, and I do what I can around here. I'm at school between 6:15 and 6:30. I teach a 7 o'clock class. I have one class where I have 2 classes at once. You know, I have to make sure all the AEDs are right. I help my athletic trainers with their taping and writing accident reports. Then I do all the impact testing for all the concussion. So that fills my time a lot.
I mean, she pushes you. She finds your likes, be it medicine or not medicine, and she pushes you to exceed and to basically get your full potential. She has some of the hardest classes to this day in sports medicine, which, you know, a lot of us took. A lot of us decided, do we like this, do we not like this?
We learned about basic first aid, how to take care of a patient on scene. Last year I was the athletic trainer for basketball, and I think I'll do it again this year.
I had knee surgery twice on my ACL, and so going through the physical therapy process made me interested in it. But then I got to my freshman year and got to be in her class. I was like, oh my goodness, I could actually be one of those people that helped me like that.
Today's workout is going to be primarily what we call 30, 60, 60s. They've not done it before. We get all of that. It's a workout before the meet itself, and so we don't want to have a really tough workout today. Alec? Very good. They just had a long bus ride yesterday and a long.
There's a lot of young people in this town that have either went on to something bigger and better that may not not of just because of her encouragement.
She has sports medicine classes, she has an EMR, a first responder class that you get state certified in. She has a medical terminology class, so some of these are college level classes. You know, you meet Bobby's expectations and then you get to move on and you get to come to the hospital, you get to do rotations at the hospital, but then she also picks out those people who have that interest in pre-hospital care.
Bobby's done so much for our community, and I thought that it was important to nominate her only because someone needs to show her that she's pretty darn amazing.
You know, sometimes I look at kids and think, I gotta be here until they graduate. But there'll come a time when I won't be able to do that, I suppose. But I just want to see it go on. I'm pretty lucky. The kids that take my class are kids that really want to do those kinds of things. That's important to them.
Very well done.
Very well deserved.
Yes.
Absolutely.
Having worked with Bobby for many, many years.
I can assure you that when this was finished, she got a standing ovation of all the people in the room, and it went on for quite some time.
You got it in 1915 too. Been here for at least 150 years. Not changed, it's exactly the same. Still doing it.
We'll move on. Consent agenda, is anything in there we want to discuss? If not, I would ask for a motion.
I'll move we approve the consent agenda as presented.
Second.
Moved and second, those in favor? Aye. Thank you. Let's see. Financial report, Cheryl.
Okay. Year to date, we saw 45 less patients for the first 3 months of this year than we did last year. Month to month, our patient counts were pretty steady between August and September, I'm looking at, except for here. The ED was up quite a bit. Patient counts in swing bed were also up from 5 and 4 to 12. Lab and radiology were very busy this month. The health clinic was very busy. We're not really sure what the average to expect there is, but we had a good increase there. We see home health is slowing down again. We kind of got used to being in those 60s, 30s, and 60s and had a few really busy months. And you see that's kind of slowing down again. We're just going to start looking at census numbers. I think that I pulled the census numbers that we publish regularly on our full census report. People try to add census for, what's the one chart? The acute.
We want to be able to show swing
Swing bed.
beds.
Separate,
Oh.
yeah. So I'll try to get that for next month, but for this month I did get the acute numbers. And then the average length of stay, which we really don't want to go much over 4. It's a good one to watch.
For acute. For swing
Yeah,
bed, will
for
be
acute,
longer.
absolutely, absolutely. Our monthly revenue, our average monthly revenue, the monthly revenue for September was $2.3 million. That was $70,000 less than it was in August. Our total revenue to date through September is higher than last year's revenue by $236,000. And our average revenue, even though we're very early in the year, is up $130,000 a month. Just good to see. Sorry. Our days in AR is right here. It dropped 3 days to 73. Unfortunately, we got a big check on, Federal's hold up with swing bed payments, and the big payment came in on November 2nd, so that would have helped a few days as well, but at least we did get that $150,000. So it's kind of headed in the right direction. I don't really think that we're gonna improve greatly on this number until we really are working out some of our issues with clinic billing. But we have recognized we've got to hire a new person, we've got to move some people around, so I do think it's gonna take us a few months from now before we can kind of get this where we want it to be again. It won't happen overnight. Our days cash on hand dropped to 143. This is a lot related to the fact that today I actually transferred $850,000 from Lakeview Gardens bank account to Lake Health District's bank account. I really didn't want to start transferring cash until the auditors had been here and we talked about how it's a very muddy situation, so I just kind of wanted to leave the cash where it was. But at this point, we've decided we're good to move. But that's really having a big impact on our days cash on hand, as well as the fact that our AR is higher than we'd like it to be. Our days in AR and our AR is higher. So those two things will help this number come back up. All right, so our P&L, we lost $25,000 this month. One of the first things I noticed, I'm not sure if you guys did, but our census was really good, but our revenue went down. And so looking into that, interestingly enough, the days, the time people spent in acute was down month over month by almost a third. So we had the same number of patients, but they didn't stay for as long. So that had an interesting impact on revenue. Our revenue is $211,000 below what we budgeted. One of the big issues, if you looked at the detailed P&L, is we're struggling with is our surgical revenue is not where we budgeted for it to be. It's definitely not grown as fast as we anticipated it would with the new surgeon coming in. So materials and services was up. I'm sorry, I couldn't find it, but it was up month over month by almost $100,000. Main reason behind that was that the pharmacy had inventory in August, so they didn't do an order, so they doubled their order in September. We could have maybe accrued for that number, but pharmacy, they really have a highly variable number, expense number. The cost of drugs is pretty sensitive. Some drugs are very expensive and some drugs are not. It's really hard for me to estimate what that cost would be. So I find that it's kind of almost better not to try because then it just looks more fluid than it does now. So
On a month-to-month basis, just September it could be jumping, but your variance for the year is very small.
Right.
So we look at that as a smoothing effect.
the year-to-date numbers, I do prefer to kind of focus on year-to-date numbers, and you're right, so year-to-date, we're a lot closer to where that we expected, or lower, but, right. Because we're small, you know, if the way that we expense things, it's not always in perfect sequence, so you do have some ups and downs in your months. It's just to be expected. So the last thing is, oh, that's okay, was we got $70,000 from the ORHQN grant, which helped out to that bottom line. Questions on income? Okay, balance sheet. I had good questions about, so this is our current month, 1.4 million, and questions about how did we go from here to here, and then looking from here to here. So the thing is that this money and this money is just cash in one Washington Federal Bank account. We keep it in 2 different GL accounts, one that's called operating cash and one that's called investments. I don't really know why. I mean, I would kind of assume it's because we used to use that strictly for operating, and we like to kind of keep track of. But now that we're using Umpqua Bank some, as well as Washington Fed and US Bank, this account got low. So we just did a journal entry to move it from one GL account to the other. The other real reason why this is down is because we've left that money in Lakeview Gardens. So when you add the 850 that I transferred today, that'll bring this number back up to where, closer to where it was last month. Does that make sense?
You still have to work on the accounts receivable.
We still have to work on the accounts receivable. And because of, I went ahead and, this is the first time I've separated out our patient accounts receivable from our other receivables, because what's in other receivables is mostly the money that Lakeview Gardens owes the district, as well as what Goose Lake Medical owes the district. So I do think you're right, we want to watch patient accounts receivable, so let's separate it out here so we can see what that is. So that because that cash got moved today, you're not really gonna see that change in next month's financials either, you won't see it until November, but that would be that. So, I had a couple things I wanted to just touch on briefly before we move on at all, because we wanna keep Lakeview Gardens separate from Lake Elk District. Since all of you have expressed to me it would be great if we had less checks to sign and use more electronic banking, we are in a place now where we're ready to go and start using ACH to push payments to our vendors. So I wanted to make sure that we're all good with that. You won't get any different information than you got before. You'll still get a page with a list of all the payments we're gonna make, all the invoices behind it. We still won't make any of the payments until you sign off on it. We have noticed a lot of our vendors are opting out of the credit card payments because it costs them quite a bit of money. So therefore, our checks are growing again instead of shrinking. So this really, and we'll need to do it kind of slowly. You have to reach out to the vendors and get their information and kind of make sure it's all going to work. You can't just kind of do them all at once, so it'll be a slow roll out. But I think it will really mostly, it's just going to reduce the number of checks that you're going to sign.
So that's just a bank transfer is what it is?
Yeah.
ACH automatic transfer.
Very similar. So you'll see all the documentation. We sign one and then it's pushed electronically.
The same as when you sign the electronic payments that we're doing now, but that's essentially paying with a credit card. So it's the same thing where you see the list and you have all the invoices that are behind it. But
The credit card made us a little money.
the credit card does make us a little money, but people are kind of catching on to the fact that it's costing them a lot of money, and more and more of our big vendors are saying there's no way that you're going to pay us that way. So, and I guess that kind of, it bothers me a little bit. I think it's not good business to pay to get your money, from your vendors. It's not a really good choice, so I don't see it lasting anyway. We're not actually going to move anyone off that, who's on that plan, but the people who've gone off of it, it'd be nice to move them on to the ACH. Okay. The other thing I wanted to talk about is I have a lease proposal. We've talked about this kind of before, but what we'd like to do is I have a proposal from Umpqua Bank. It's a master lease. It lasts for the term of a year. We can lease up to $1 million. The point of it is that if and when we decide to buy any assets, we can choose to put them on this lease or not. I mean, it would be totally up to us. But it would be such that this credit would be in place so we could easily use it as the year goes by. Another benefit would be that we could lock the rate in right now. We just basically, the rate they've offered me is 2.88%. We would pay it back on a 3-year basis. I would probably add to it on the quarterly. I would just, we'd probably pay cash during the quarter, come to the end of the quarter. If you bought 2 or 3 things, if you want to, you can finance it, you know, totally if you choose. It's just a way for us to preserve cash if we decide that's what we want to do, without having to initiate several different leases, which then really costs me quite a bit of time to manage those leases, to make
This is
payments. and-
approximately a line of credit then.
Sort of, yeah.
Why do they use the term lease for that?
Because you are leasing it, you'll own the assets. The purpose of it is to allow you to buy assets. You can't just borrow money because you have to buy an asset. You have to prove that you bought something that
And
has
then is there a
value.
lien involved then, Cheryl, with that?
I don't know, we didn't talk about recording any liens, but that does, you know, they don't want you, it's not for you to use for operating purposes, or you just have to prove that you used it to purchase an asset. But but then essentially it's the same. There's not a recorded lien. I mean, I would say that there's a contracted type of arrangement, but they don't record,
UCC.
thank you, yeah.
Do we have a need for that?
We don't really, no, we don't have a need to borrow money. I would not be able to say yes to that. But is it better to use your cash to, you know, to preserve your cash, to have your day's cash on hand? Maybe we want to preserve our day's cash on hand because we made a commitment to the bank on the bonds to have at least 90 days cash on hand. I mean, from my point of view, should you borrow money if you don't have to? No. But if we could use the money to make money and we're only paying 3%, I mean, it's definitely at each point of, you know, we're at this point in time, would it be better for us to lease or would it be better for us to just pay cash?
But we're not talking just the cost of operations, we're talking about asset purchases.
Right, and in our capital budget, we did budget for roughly $1 million of things that we could buy or improvements that we need to make, like to the building out back. So we're buying a mobile home, things of that nature.
One of the things as an example, we have, when we buy lab equipment, a lot of times what will happen is the vendor will sell us the piece of equipment, but where they really make their money is selling the reagents that are used in that piece of lab equipment. So every time we do a lab test, they're selling us the reagent to test it. And so they structure an agreement that says, we'll sell you this equipment. You have an obligation to buy all these reagents, and we'll combine them into one deal. If we separate out the purchase process and buy the reagents separately, sometimes we can get rid of the finance charges that they're charging us, which are often much higher than this rate. So
But you do the same thing with cash.
Exactly.
you could,
Yeah.
you could use cash for it, if they're willing to do that. Sometimes they're not willing to. It varies.
But essentially, you're saying this is an available line of credit at an interest rate we can lock in.
Yes.
Any fee involved?
And you don't have to use it. Right, so if you don't use it all year long, it really doesn't matter. It's just kind of a nice to have kind of thing. And also, you know, our interest rate is gonna go up, I don't know, property, so we've just, you know, kind of talked about managing our cash and what are all the right things that we can do to ensure that we can manage the cash, you know, the way we think is best. And really, it does save you time. The more leases we have, the more, it just does take time to make the payments, to make sure you make the payments on time, you know, write the checks and keep your accounting straight on your long and short-term leases and interest expenses.
But is this a short time payback period?
It's a 3-year payback period, which is pretty much what I would choose for most of the types of assets that we're buying. that
How
we
do you
would-
budget, how do you put that in your budget, 3-year payback time?
How do you put that in your budget?
Well, it seems to me like when we budget for capital expenditures, that we buy those as we need them, as we can afford them. But this then gives us, basically.
Well,
more
we've signed, you
flexibility.
know, let's see, in the time I've been here, we haven't signed very many leases for smaller equipment. But we've got, I mean, we did lease the MRI on a 5-year finance. It doesn't make sense to sign, you know, to have a bunch of small leases. This makes it so that instead of having, you know, 3 or 4 leases that are $50,000, you've just got one that might be a couple $100,000.
But I don't understand why you don't lease the cash for those, Cheryl, I guess that's where I'm confused.
Well, it won't be something necessarily that I decide. I mean, I certainly wouldn't choose to lease or not lease without the board's approval. We don't buy or not, you know, we let you guys know whenever we're buying something. It just gives us a safe interest rate for a year.
For 1 year?
Yeah, it's a 1-year, 12-month.
So if you buy something this year, you gotta pay it back in 3 years' time. And you got a fixed rate, but it's not a revolving account going on year after year.
No, you can only add to it during the next 12 months. I'm sure they'd love to renegotiate, they're just gonna protect their interest rate ability.
So they have the assurance, the agreement is during the year, 12-month period, the interest rate at any time that you access it is 2.87. After, from when you use that money, it's good for 3 years. But at the end of 1 year, it may go up. Should we want to do it?
Is this good for any asset or just equipment?
Well, it'd have to be a tangible, I don't,
Well, I mean, like a building, you need to build a building with it?
yeah, well, like a mobile home. No, I don't think you could build a building. I guess I didn't really ask that, but yeah, generally movable equipment.
Probably personal property.
Yeah.
And under
Yeah.
a lease, they would technically own it.
Right.
There wouldn't be a UCC payment because they own it.
Well, that's- yeah. Really, it's just in case we decide that that's how we want to manage our cash, given all the things that we've going on this year.
Are you concerned that our cash is going to be low?
Well, I'm quite sure that it's gonna go down. I mean, there's no doubt about it as we go to long-term care. We're going to use cash for long-term care. I don't see any other reason why it would go down. And I would say operations are going well so far. I don't know why that would change.
I would guess that next year Medicare might tighten up if we show profits. We might end up with less cash next year.
Yeah.
But if we get into those situations, then we need to look at cuts. We don't need to look at, okay, let's borrow ourselves out of this.
Yeah.
Yeah.
It's just a tool that could be available to us if we decide we need it.
Right, and given low interest rates, sometimes it is better to just go ahead and borrow it if you can use the money to make money elsewhere.
I don't see a harm to having a commitment if it costs us nothing.
And, but I guess that's what I'm talking about, too. That's just a,
No cost, and then you come to the board if you need something.
right, we would not use the lease without, I mean, the board would certainly know ahead of time. Yeah,
Just like with
absolutely.
everything else that we do,
Yeah.
we're not.
I have no problem.
Let's
I'm
make-
really hesitant. Yes, I really am hesitant. It just seems like, to me, that we're just borrowing more money and more money.
Could be.
And more money. The only reason that I could say yes to this is on the absolute idea that you do not spend it unless it's board approved. that we do not access it unless it's board approved. We need to be fiscally really responsible right now.
Yeah. Yeah, when you're spending a lot of money, it's.
Yes, we are.
Yeah.
I think that's absolutely, that's what, no.
Would anybody like to make a motion one way or the other?
Does this need a motion?
We're gonna authorize commitment to the bank.
If it doesn't, it should. I would, I don't have a problem with it as long as it's reported back to the board and we make approval on usage. So that's, I'd say we approve the lease proposal contingent on that the board is, approves the actual usage of the lease.
And there's no fee in charge, and no fee involved.
In 1 year. In 1 year, yeah.
Did I get a second?
Not for me.
Judy, you got any thoughts?
I'll second it under the stipulation that, like I just said, that we absolutely are presented with any notion or idea or suggestion that we access this money.
And I would just say it's a temptation that to spend more, and I think we need to look at the balance. And yeah, I just agree with that.
I think we all agree to that. It's something that the board has to absolutely approve. Any expenditures.
I feel like we have to rely on the idea that as fiscal managers of this facility, that you know what you're doing, you know what your presentation to us is, Charlie is the same, you feel that that is fiscally the correct thing to do. You certainly know more than I know, but I want the ability for the board to say yes or no when it comes time to access that money.
There's a motion on the table. Those in favor?
Aye.
Aye. Those opposed? Aye. All right, thank you. Motion does pass. All right, let's move on to your next
Oh.
subject.
One of the things that Moss Adams has been talking about, I think we've talked a little bit about this individually, we talked about it in the finance meeting, is Moss Adams in their auditing process wants to ensure that we do all that we can to ensure that there is a clear distinction between Lakeview Gardens and Lake Health District. And they've talked about lots of different ways that we can show that separation. Certainly one of the things that's going to help us is by having the new software that we are getting point click. It starts in, I believe it's in December.
December 1st.
December 1st. We're going to go to a different software so we don't have Lakeview Gardens accounts receivable commingled with the districts. And we have financial separation, but we've been doing it more journal-wise than as much as Moss Adams would like to see. They'd like to see more, as much as we can. Their concern, of course, is the possibility that it could be viewed as a rolled-up company.
Excuse me, wasn't it in the past, the big deal was the physical separation of the buildings, the separate metering of electricity and water and all of that?
Yes. Yes.
We're going to have that.
We will.
Yeah.
In the meantime, they want more paper.
So one possible suggestion is that we could approve the financial report for Lake Health District and review the financial report for Lakeview Gardens, showing the distinction. So if you financial report for Lake Health District, and then we provide you Lakeview Gardens information, but you're not approving this.
You know, I have one problem personally with that, Charlie, is we're approving something that we don't have great expertise in, and it's unaudited at that point.
True.
I don't know if that's appropriate or not. We should approve something we really don't know if the numbers given to us are perfect. We rely on our auditor for that purpose.
Right. Historically, you haven't approved financials.
Right, we don't approve.
You don't really have to approve them.
We listen to it, we don't approve.
Right.
You're not-
Review it.
So it's reviewed. But again, we're trying to assist. The biggest concern that Moss Adams has is that they're too close together, the two companies. And we're trying as hard as we can to show it's not. But they want to be assured of that. So you don't have to approve it, but I thought maybe that might be a way of helping identify the difference between the district financials and information about Lakeview Gardens.
So Dave, have you got any suggestions how we can do that? We're still protecting the board too.
I guess you could spend the money to have an audit
We do that
on
every
the
month.
Lakeview Gardens
We
every year.
We do
Yeah.
that, but not every month.
Not every month.
They're asking us to approve each month, is my understanding.
Well, what it would just say is you approved the presentation, knowing it's not audited. It is it's our presentation. Not that you're accepting it as gospel, that that's what you're really asking is that the auditors verify what we are doing, what we're reporting to you is in fact accurate. And that's what they do every year. So
MoDOC approves the financial presentation of their unaudited financials monthly. That's one of the things I noticed in the minutes that he sent me for review.
I think if you're blessing it or approving it, you're going to be responsible for it.
But we don't approve it here.
So
You're
you don't
presenting
have-
us with information, there's no formal approval done. This is an interim financial statement.
Oh, you're talking about the hospitals?
Both of them, hospital and the
You
gardens and.
have the responsibility for the hospital, whether you approve it or don't approve it. As board members,
Right, for the hospital, we have the responsibility for it, so there's no approval down there. We don't move or make a motion.
I think,
It's implied.
Yeah.
Sure, it's implied.
you're supposed to have a monthly meeting and your duty is to see what comes in and goes out and make sure it's adequate. You're deemed to be responsible for everything that happens. So even if you're not approving it, I guess if you're not objecting it, you're approving it.
Okay.
And I don't think you have that responsibility on the other one, so if you'd be taking that on.
Again, they're not clear exactly on what they're saying, how do you prove this separation. We're showing everything that we can, that they are absolutely separate. So this was just a suggestion. We don't have to if you don't want to.
I separated out the worksheets, so I'll send you 2 worksheets every month, one for Lake Health and one for Lakeview Gardens, or Goose Lake really, so it has Goose Lake and Lakeview Gardens on it. But, so I figured I'd just send you 2 different reports, so they're just really separate.
I mean, you're concerned about how it performs, right?
Oh, absolutely, that's
So, I mean, I
one of our
think
main duties.
A report of some sort of how it's doing is,
That's why she gives us the report.
yeah, but that'd be just informational.
But Charlie's asking that, suggesting that we make a formal
Just to show you
motion
it's-
that we've accepted.
I think that makes it more intertwined than less.
You do?
Approving LHD, but not Lakeview Gardens.
Oh, okay. That would actually make it the other way around.
That was the intent.
I thought you wanted to improve.
No. It was, your distinction is you understand your financial responsibility, our obligation to you is to provide you with adequate, accurate information at all times. We have two companies. One that you are the board of, the other you're interested in. You're not, this is not the board for Goose Lake and Lakeview Gardens.
So you would like us to have a motion to accept the unaudited report for this month?
Yes. And that the other is informationally presented to you. It's same as accurate as information as we can get.
For Lake Health District.
For Lake Health, for,
I think you're just approving the expenditures, paying the bills, is what you meant to do. Why you'd approve the whole thing.
Well, that's the whole financial report.
Yeah. Accept an authorized payment of the, you do that after the
We
fact.
do it anyway, yes. Anybody else have a thought on that?
we can wait to get Moss Adams to say if they think that that would help in the separation.
Right.
If that would be.
Are you okay doing that, Charlie?
I am. Again, what the intent is to try and help ensure the separation. That's really, we're doing it to the best of our ability. We're trying to continue showing that there is a separation. And if that would help, great. If it doesn't make any difference, then
Might be able to form a committee and as we tend to review it.
We have a committee. Is
You
there
guys, same people?
the finance
Yes,
committee.
and people.
Yeah.
So,
And Don and Judy.
But not, there's nobody else besides two board members.
For
Now,
for Lakeview Gardens.
Or Lakeview Gardens.
That does.
okay, Charlie, shouldn't this financial report be given, if you want to do it this way, monthly to the board members of those other two entities?
Yes, and that is our intent to do that. So we had the Lakeview Gardens board meeting last month to approve the agreements for the refinancing loan. But we're trying to, I don't want to make it onerous where we have lots and lots of board meetings and everybody's got lots to do. But at the same time, we do want to keep showing the separation and keeping you informed.
Couldn't we just have the minutes of the Lakeview Garden board meeting reported to us? And part of that would be the financials?
We certainly could do that.
and maybe do it.
So it's their report to us.
But, and we don't have an obligation but once a month to have a meeting. At the same time, we still are.
Once a year.
Oh, excuse me, once a year, sorry. But for Lakeview Gardens. But we still want to give you as much current information. So it's, and we can mail out the information to Lakeview Gardens board members. And we're happy to do that.
I think that does prove your intent too.
Sure. Okay. Then if that's okay, we'll be happy to do that. And see if that meets with Moss Adams, with the intent. I mean, that is what the intent is, so.
Okay, let's go on to the next issue.
Okay, then, oh, so we didn't talk about Lakeview Gardens real quick?
Yeah.
Okay. Lakeview Gardens, census has been down, the revenue is down a little bit. So they ended the month with a $37,000 loss at $53,000 for the year. Their balance sheet really didn't change, except you see that a large amount of cash that's been building up as we've gone through these past few months, and they've started really collecting on their ODR. Goose Lake Medical Services, we did get bills out the door under our new program, eClinical. Now we're dealing with, CMS came back to us and we submitted the cost report for the year. And our Moss Adams was very surprised to find out that CMS expected them to produce 2 reports, one for Stevens Park and one for Goose Lake. So now Medicare is not paying us because they want those 2 cost reports, and Moss Adams is working on it. and they should have that done soon, and we'll release our Medicare money.
Is that accrued in there?
Yeah, the revenues reported, it's just the cash is not coming in. Because we report, you know, the revenue when the bill goes out, so. We did send out the bills. We were not able to really run reports out of eClinical yet. How soon do you think we're gonna have good reports?
Next week.
Next week. So, another challenge with eClinical. So, I mean, it's good that the bills are out. It's not good that we need to run the revenue reports out of eClinical and then put that amount into QuickBooks, because we're doing our accounting in QuickBooks for Goose Lake Medical. So, anyway, so they, we did and recorded the revenue that we could determine specifically, and so it's less than what it should be. So we're still really not, I mean, I'm not believing that we've lost $50,000 year to date, so, but it's gonna take me another month or so before we'll have that squared away.
2016.
Well, we're on fiscal year, so it's fiscal 2016, which starts on June 1st to July 1st of 50, yeah. Okay.
Always something with Goose Lake.
Well, keep in mind that,
I mean, I've been here every month I've been on the board.
Yeah.
It's always something. Is there any light, Cheryl, at the end of the tunnel?
Yeah, I think there's a lot of light at the end of the tunnel. I think there's a ton of potential, and I think that having Juanita here to actually keep it going, I cannot manage, Brian and I can't manage a clinic 50 miles away. It's not, it doesn't work.
So this is the light we're seeing here.
This is the light. I don't want to put too much pressure on Juanita.
Oh, good.
But
I like it.
she's already figured out how to save us $400 a month. She's got a lot of good ideas, and I think that she thinks there's a lot of potential down there, a lot of demand.
But it's an area of frustration for me. That this continues month after month after month after month. It's the building, it's the doctors, it's the Medicaid, it's,
Well,
I
so
don't know
it's a
where it all
bump in
is.
the road.
But the
It
bottom
comes.
line is, we're
It-
losing money, see?
But we lost, I think, $18,000 in total last year. But I don't think that, we aren't really able to see, we know that our revenue from California went from $500,000 to $3 million in the space of 4 years. No, you can't attribute it totally to that clinic down there, but you have to think that having a presence down there is making a difference. One of the things we're working on now is, again, is getting all of the lab work down to come up from down there. That would be a lot of money for our lab. Certainly would pay for a
And
lot of.
I've heard that for a year, see, so that's my issue.
Well, what are we gonna do about the lab?
We have a phlebotomist which is what one of the providers wanted. We wanted a phlebotomist, so we have an MA here that's also a phlebotomist that would like to work in that clinic. She's going to train with the lab here for a couple of days to make sure she's able to stick people in. And then the commitment from Dr. Gilbertson has been with the phlebotomist there. She will make sure she sends her labs here. She's not happy with the lab in California. She's not happy with that.
The service?
They're not getting accurate reports back or timely or even getting reports at some point. So she really wants to utilize those services. So we're going to move forward with that right away and make sure that she's getting them. And then hopefully with her seeing the turnaround and the lab's availability quickly within her clinical, then Dr. Stevens will come on board with that as well.
Well, I'm happy to see Juanita on board, and so we'll just see where it goes.
We will keep working on it and make sure that we're getting labs and other ancillary services that we can get through there. They're not getting their X-ray reports or, they're not getting patients up here, so we definitely want to work on that and make sure that that's happening.
Have a
we doing as far as having enough providers to meet our demand?
We actually interviewed a nurse practitioner who's coming down for a second interview, who's interested in that. He'll be here November 16th to tour the clinic, and he's bringing his wife. He has a young child, so he's kind of interested in those things. Looked like we had another locum agreement that we're looking at. We have some different recruiter options out there. The only interview so far has been that nurse practitioner. He does seem very interested in the clinic, and he interviewed in a week and wanted to come down the next week, so I think that's a good sign.
We need another provider down there.
Easy.
Really badly.
If you recall, Roseanne left in September, or in August, to come up here. And we've been trying to find people. And Roseanne was only working part-time, so to answer your question, if we have enough providers, no, we don't. We need more practitioners.
A lot of unmet demand.
Well, Juanita, we're glad to have you on board because, trust me, this has been a ongoing discussion for many years now. And there's a lot of frustration, I think,
I understand.
where we haven't gone and what we have to overcome and what we need to do to make a change and to get things going in a positive way. So,
Absolutely.
not to put a lot of weight on your shoulders, but
Welcome to Lakeview.
good luck.
No, I think it's going to be
It's a
fun.
big job.
Yeah.
It is,
It is a
absolutely.
big job.
And that's why we need you.
Yes.
Yes.
Absolutely.
Okay, let's move on. Anything further from you, Cheryl?
No.
All right, Charlie, construction update.
This is in reference to the clinic, or Lakeview Gardens. Sorry. You all saw the note that I sent out about the adroit projections.
I got it.
You got it. So we are meeting. We're meeting with Adroit. We're meeting with Pinnacle. They're working on. They're making adjustments. So we probably, based on the last information I got from Adroit this afternoon, was we probably will have final plans drawn by the end of November, which would mean that they would have to put it out to bid for, and that would be at least 3 weeks. He does not anticipate they'll get good responses from the contractors before Christmas. So it may be shortly thereafter. So the estimates that you saw, that I sent you, were not final bids from contractors. Those were their estimates based on drawings that were about 75% drawn. So,
Am I wrong? Or weren't we anticipating to have this thing ready to go mid-November?
we have been pushing as hard as we can to get it done. Pinnacle says that it'll take them a month before they have their drawings done. We did pick a smaller architectural firm. And I think that they're going as fast as they can.
And at that point, they have a number, a bottom line number.
Well, we will have a final bottom line number. Part of the process is to look at, given a design, what should we or should we not do? So when we look at concrete, as you pointed out, it may be cheaper for us to do asphalt instead of concrete, some of the sidewalks. It may be cheaper for us to, depending on how the floor is put in, it changes based on the location of the stoves, depending on the kind of the cooktop, because it's not just the ovens, it's the location that would cause the difference to be in the fire suppressant system. So there are a lot of differences that still have yet to be, had to be designed. And they're working. But I think it's important to keep you apprised of what's going on.
No firm date when we'll know something.
Well, Adroit can't give us a firm price until they have final drawings. They can't get the final drawings for another 30 days from Pinnacle. Because then when Adroit sends it out to their subcontractors, that's when they get the final pricing, or as close to the final pricing as they can get. So that's
30 days plus them the bids. Is that
30 days to
correct?
complete the design. Then 30 days, because they have to send those out to the subcontractors. They just last Monday got the geotechnical report from Anderson Engineering that defined how much compaction requirements were, which defined how much earthwork they did and how much concrete they did. So there's a lot of moving parts in this process. And no matter how much we push it, I can't get it any faster.
Basically, it sounds like it'll be the first of the year.
That would be my guess.
We still, we go to the Lakeview Planning Commission Monday night, the night for land use permit. And we had to do more narrative descriptions for certificate of need, which that was sent in within a few days of receiving this other over a page of requests from them that we didn't know. So we are on the list as a project to move fast,
Expedite review.
but we don't have confirmation of it yet from the state, which we had hoped to have last month.
Heck, we submitted that back in May, and then June, and we thought it would be done by October. Right. And we just got comments saying, would you send us this letter? It's frustrating.
So then, Charlie, we get a number for early January. Then we have the option of negotiating that number?
Well, if the number is more than you want to spend, and we have a good idea that clearly what we want to say is, no, we're not going to do this component. We're not going to do that. I mean, that's where we are. But part of the decision, for example, is what kind of heating system. Whether, is geothermal the most cost effective? It costs more money in some parts, but it heats differently. Do we put in electrical? How do we handle it? Is it a combination? So they've looked at a variety of different systems for heating and air conditioning.
But why aren't we making a decision and saying this is what we'll do and then let it go forward?
So what we did is, based on that estimates that Adroit gave us, said, we're not going to go this one, we're going to go to this one. We still haven't got a firm estimate, but that's their best estimate.
Have they given you area cost to go one way or another, for instance, on the heating?
They did, at our meeting.
Okay.
And we changed from what Adroit said, I don't know exactly what you're going to tell me. And so we talked about, let's pick the lesser expensive. What we didn't know, because we didn't have the geotechnical report from Anderson Engineering, is how much concrete was going to be required, which defined what kind of flooring and how much concrete you had to pour for them. So that there's still a lot of information.
Are the rooms going to be individually controlled? Or
Yes.
is he?
Yes.
So some of the heat, for example, what it appears that where the design, as we left it, was we would be putting radiant heating, geothermal, in throughout the building. And then in each individual room, they use something like the Mitsubishi system that many of you have seen, where it individually allows heating and cooling, but you have airflow throughout the main corridors and then into each individual room, because you want to be able to control heating in the room, heating in the centralized locations. So you want to be able to balance that and do that most efficiently and most cost effective.
We've also been, the design team has had their second meeting was today, and we did look at, we're being presented with some alternative flooring, you know, just to manage expense. And so we'll have a better idea on the cost, cutting the rock work on the exterior as well as the interior around the fireplace. You know, we're trying to make all the cuts we can.
What did we approve at our meeting that we had?
$6.2 million.
And at that time, at least was my understanding, for that 6.2, we were gonna get this. And now that's all kind of flowing back and forth, right?
Well, I think you have to take one thing in mind, and that is that $6.2 million was the estimate based back in June. Construction costs have gone up in the Pacific Northwest.
But Charlie, they know that. They know those things. That's their business.
But I don't know as how any more than they can predict what the interest rate is today or what it's going to be in January. I don't know as how anybody can predict it. Now, if they could, and we could hold them to that, then if we have to adjust our costs based on that, then we do.
I just don't want us to end up with an inferior product.
Yeah, it's a one-shot deal. Right.
I don't think anybody wants to have an inferior product. I would agree with you.
Okay. Medical staff report. Darby,
We have no privileging information. Dr. Graham is not able to be here tonight, so we don't have a report.
all right, well, we do have a nursing report.
Yes, we do. I believe you received, did you receive a policy for approval? Yes. So it probably doesn't seem very necessary to you, so I'll tell you the background, which is we were advised to try to move our infection control committee into a quality realm so that what we do is not recoverable in the event there were some, you know, that it becomes more confidential in this way. So we've changed the name of it in doing that, this is one of those policies that I felt like I needed to bring to you because it's more in the realm of directing us how we do our infection prevention. So we're moving in that direction. So other than that, it's kind of just business as usual, other than the change of the name. So, any questions about that?
I can ask for a motion to approve this policy so we can sign it.
So moved.
Second. I'll second that.
Those in favor?
Aye.
Thank you.
Who's my signer? Chuck is my signer? Okay. Well, I know sometimes it's the secretary. All right, and then I did bring you some handouts that you didn't get in the mail. So I'll pass those out. So I have some good news. Would you guys like some good news?
Yeah,
Yeah. So you may know, I think you've heard Nom talk a little bit about some of the work we've been doing on the cows or the computers on wheels that the nurses use. And that we had done quite a bit of work in determining, we had some demos in that we used for a month, and we made some choices, and in that process, we have also been working really hard at getting the nurses to do bedside medication verification, which means they scan the patient's armband as well as the medication itself. So it really cuts down on the possibility for error
And so we've been working on this actually since, I guess, probably springtime. I don't know if anybody else wants some copies. So we've been working on this since spring, and we have some numbers here. It's the single piece of paper. So we have some numbers here which have really come quite a long ways. You can, so we divided them into nurses that were in the green, meaning they were meeting our expectations 70% of the time or more. Yellow nurses were 25 to 69%, and then red was 24% or below. So that's number of nurses meeting our expectations at that certain percent of the time. So when we started this, we only had 38% of the nurses in the green, when we're now up to 78%. And when we had 42 in yellow, and we're down to 22, and the number in red has gone to 0. So we've had a huge improvement in this, and Nom deserves a lot of credit, as well as the nursing staff who've been, because it is more time consuming, that's the problem. And there are barriers. You could never achieve this 100% of the time. Not all meds can, there's just a variety of reasons why it doesn't always work. But I felt like this was a really important patient safety item, and we had been struggling with it. So that we've made good progress. So that's one piece of good news. The other piece of good news is in relation to the meaningful use statistics. So as you might recall, meaningful use means that in the eyes of Medicaid, we're using our electronic medical record in a meaningful way. That's the meaning behind the meaningful use term. So they have certain things that they measure us on, and some of those measures we met early on with meaningful use stage 1, and some of those measures were easy, and so they've actually retired some of them. And then meaningful use stage 2 we've been struggling with in particular in relation to doctors entering orders for radiology and lab. So the term CPOE means computer physician order entry. So I put a star by radiology because that was the one we struggled most with. But I'm happy to report that the T system, since we've gotten the T system in the emergency room, the contribution of the T system has put us over the edge, and we are now in our first month of being completely compliant. We have to meet it for three consecutive months. And we may be doing so well that we can drag September along with it because it's an average. So we may be able to use September, October, November as our attestation months. So what's attached is the results pulled out of the T system, and none of these matter because we don't really measure the emergency room. The only reason the emergency room affects us is if the patient's admitted on into acute, then we have to look at whether or not there were physician order entries done in the emergency room. So only those two areas really matter, the two starred ones. So that's really helped, and the good news is maybe the expense that we spent on the T system, we'll get some of that back when we get our meaningful use money back. So we're hopeful. We aren't there yet, but we are hopeful with that. I guess the downside, to meaningful use is next year we have to do this all year. So and we have to add in electronic prescribing. So that'll be our next challenge because we'll need to start doing that by January. But these are the little idea of what our measures are, what they're looking at in terms of how we use our medical record, how we use the patient portal, how we do patient education, medication reconciliation, and also how well we send information electronically when a patient is transferred. Those are all the things that are very important to those folks who made up these measures. So, any questions from you?
You got med reconciliation and summary of care, are we still low on those?
So med reconciliation, we're not,
Oh, we're above the.
yeah, we're above the expectation in all those areas.
Yeah,
Summary of care,
we're good.
yeah, that's kind of a download that we do and then we print it and send along with a patient who's transferred. The one that's a little bit tricky is the view, download, and transmit to a third party. We actually have to transmit through a direct messaging system to other hospitals. And we have that set up with St. Charles and OHSU, but the ability to send it to Asante and Sky Lakes is hindered by the fact that in order to do that, we have to join an alliance that is very expensive. So we can't get their direct messaging address and utilize that unless we join the Jefferson Health Exchange.
But one of the things about the Jefferson Health Exchange, so when you think about electronic records, we have an electronic record here that we control, it's ours, it doesn't go outside. If we send information to St. Charles or to Sky Lakes, it goes to that from one hospital to another hospital. A health information exchange is it where it goes to a central holding facility. And so a hospital sends to that, and that's information exchange sends it to the other hospital or a clinic or to a lab. So there's health information exchanges are occurring all over the country. And St. Charles has been working on one, they've not been able to be successful. The Jefferson Health Information Exchange goes from Coos Bay all the way to Sky Lakes and includes some of the doctors in Northern California. They originally came to us and said, we'd love to have you join, it would cost us $100,000. And we said, thank you very much for the opportunity, but that's way outside of our purview. They got a grant that would allow for 3 critical access hospitals to participate at the rate of $10,000. But we still have to have another $10,000 that goes to pay for the interface, God bless you, between CPSI and the Jefferson HIE. So what we send, it cost us about $10,000 to provide that information. So it's roughly $20,000.
Is that an annual fee or is that
one-time fee?
One time.
And then they have, I believe, I don't recall exactly what the annual fee is, but it's a couple $1,000. So one of the things that we're hoping is if we can continue with meeting our meaningful use requirements, we make the expenditure in this calendar year, that we can then submit to Medicare and get that money. So it makes sense to do it. Because remember, what the expenses that we make when they are information exchange or computer software, we can depreciate that and get our money back over 3 years. Much better if we get our money back right away. So that's one of the big advantages of meaningful use. So we haven't spent the money. They came back with us saying we have a great deal to offer to you. And a sizable number of our patients do go to both Sky Lakes and to the Medford area, whether it's Asante or Providence.
They don't allow you to just dump it on a CD and send it to the patient.
They do, and we have been doing that. But the bitter advantage is that if a patient goes to Asante and they have services provided, we could actually get all the electronic records back to our physicians. So it's far more information. You know, a lot of times our doctors may only get a letter. This is what happened, this is what went on. This could have far more valuable information for our doctors in the care of our community. So there are a lot of advantages. It's still expensive. So we're not just jumping. But that would help also with our transfer information.
That's all I have. We're still struggling with hiring nurses, and we're hiring a lot of new graduates, so we're in a heavy, intensive training phase.
I saw your ad in the paper.
Yes.
CNA.
The State Board of Nursing approved myself and one other RN to be instructors for the nurses aid. We had to do an online training class, and we both did that and then applied. And they approved us, and so that day I put together and started advertising for a nurses aid class. So we will share that, Maribel and I will, just to get it done. My nurse is still out from her fractured leg from her motorcycle accident, so we don't know when she'll be back. But we are getting applications in already, and we start it on the 16th.
Will you exceed the quota, do you think? Will you have to interview and?
Oh, we always do.
Oh, you always do? Oh, okay.
Yep. Yep. And I did offer the 2 well, there was actually 4 KCC students, and I did offer them first the class, and that they were automatically in our class. They had been accepted into KCC, and then when it dropped, I assured them of a spot in ours. So I only know of one has left the area, and I haven't heard back from one is starting in Roseburg. I think she's moving to Roseburg, and she'll start an aid class there. One is taking a nurse's aid class. She already moved at Lynn Benton, and one has brought me her application. So,
Speaking of KCC, do we have the nursing program going forward?
We have one student enrolled, and at this time, she's traveling to Klamath 4 days a week to participate.
and they are calling for a meeting. Did you get that notice?
Yeah.
Yeah,
Monday.
in Klamath Falls.
Keep in mind that the KCC program called for, this is a transition year. So the students that were allowed into the RN program had to have gone through the LPN program. So there was a limited number of people. The main startup will be next fall.
Yeah, we're building a pipeline of LPN people.
Now we're building a pipeline of people that have met the requirements to be accepted, not LPNs, to be accepted into the RN program. So,
And we are moving forward with KCC, came over last month to look at training areas and long-term care. We are in the process of moving our activities room to the dining room and the living room, and that room vacated for the nursing training program. So it'll be both the CNA classroom and the nurses classroom lab. So we won't have to move it again next year. So we just moved that.
We'll figure out some way you'll have to do something.
Huh?
We'll probably do something.
Oh, but
Anything else, Teresa?
I don't believe so, unless you have questions for me. That's enough. Probably heard enough from.
Do you need this back?
No, but I'll take it. I'll recycle.
Well, very good. It's nice to see that.
Thank you.
You're getting your job done there. You're getting your doctor's trained. All right, SDIS checklist. Charlie, do you want to talk about that?
sure. SDIS gives us discounts in our premiums if we meet some of the requirements that they, I didn't want to say jump to the hoops, but if we meet some of the requirements that they offer for us. And so we have sent out to you some of the suggested policy changes. Dave looked at them a little bit. Jim was not able to do that. But I think you had a great suggestion that if you could, if you have any changes to some of these policies, that, because we do have a deadline, I believe it's November 13th. If the policies that we've sent out to you, if you want to make any changes, if we could do that.
On these, the 7 that you sent us, yeah, I have some stuff on several of them.
I guess, I think you're going to need to do it in a timely fashion, but I'm not sure that those are, the way they are, I think they need some revision. positions. I think it'd be a better format to do the policies of the board and have individual position policies, just reiterate what the position of what the board policies are, and then the specific duties. I don't think, I guess when you start adopting policies, you're expected to follow them. And the ones, a lot of these ones that are in here, I don't think are necessarily, I mean, having a mission statement and stuff like that as a policy, you already have some of that, but unless you want to do that every year, it's not a requirement what the board, what the law requires the board to do. So I think that's where you'd want to look for your policies is, you know, what the statutes say the board's responsibilities are.
I think we've covered that. We're just trying to make the insurance company.
Well, I don't know if you have, but what do you, but I mean, I think that's what you'd want to, you could do a nice general policy that says, you know, we're going to follow the law.
Well, we have that as a policy.
It's not in any of the stuff you gave me.
It's in our bylaws.
No, it's in the bylaws.
Okay, then your policy can be will follow the bylaws, and you have to have some sort of a policy. I just think a lot of that is, and I think you could incorporate some of the statutory requirements and be helpful to you guys, and especially the new people that come in, to know that, you know, you're not supposed to miss 4 meetings in a row or you can be replaced, stuff like that. So,
I think those, I'm not sure about the 4 meetings, but I think it's in there somewhere, one of our.
in your bylaws?
I don't know if it's not in the bylaws, but it is in the OAR. And so your bylaws say will follow OAR. So a little bit of this is
Unnecessary.
not necessarily all that,
Yeah.
but we're trying to, if we can, without stretching, trying to meet the needs that the SDAO asks for so that we can get a reduction.
The only thing I saw when I read through those, and Judy's probably got the same thing, is that first off, our bylaws set up the election of officers every other year instead of every year. And then the heading on some of those, like the secretary's one, should have said secretary, not chairman. Just minor things.
We did have
Some of them actually change what the law says too, like anybody can call for a meeting, or special meeting, anybody can substitute for the chairman, so your guys are actually putting a procedure in there that's not necessarily required. I don't know if it matters to you, but.
And I didn't find it somewhere that it does say the progression, the chairman's not available, then.
There is a
It says
progression.
it in here.
And that,
There is a
First to
progression.
the treasurer and then to the
Yes.
secretary.
Right.
and the statute, but that's what I'm saying, the statute says any other board member can do it.
Oh, is that right?
Yeah, it doesn't, the statute doesn't say it has to be your
So somewhere
secretary.
in our existing rules,
But in our bylaws, it does. Yeah. And so
It isn't in your bylaws.
it doesn't.
I don't think so.
I couldn't find it in the bylaws today.
Yeah, I gotta send me the bylaws. So if there's something somewhere else, then
Mine is good.
So what are we doing here tonight with these, and are we approving these? I mean, or we're just,
If you're,
some of these need edited.
I understand. So if you would like, we can forego worrying about the discount.
What dollar amount are we talking about?
Last year we met 8%, and off the top of my head, I want to say it was close to a $2,000 discount on our property insurance. So if we don't meet this one, we'll still meet 4%, or we met 8 last year, so we meet 6% this year. So we wouldn't get as large a discount, but we'd have an opportunity to maybe look at this again and get that additional percentage next year, because it'll come again next year, trust me.
These didn't really say anything that doesn't exist, but I don't see any harm from it either.
In the grand scheme of things, Jerry, it's not a lot.
If they're done right.
And I pulled them from Harney County, trying to put together this information, going online, looking at different various board meetings and stuff. That's where some of this came from, is a lot of it came from Harney, and we made some edits. And I missed the fact that we do ours every other year with like your elections versus they do theirs yearly. And that's just I've only been here when they elected one time. I
Well,
didn't realize.
You know, the things that I picked up on here, with one or two exceptions, are really minor, really minor. Wouldn't take any time at all to go through these.
I would suggest you revise them to maybe even one as far as that goes, and send it out to the board members. Then, I don't see any reason we couldn't, if we all agreed on them, agreed that we would let them go forward, I'd sign, let them go forward,
Making the changes.
making the changes, and if anybody has an objection, then we would sign them.
Because we're talking all of what, $400 or $500 here maybe? What you're saying?
I believe so. I don't know what our property insurance is gonna be this year, so I couldn't give you a good dollar amount, but I know it's been, I mean, it comes up and goes down every year.
It's a
But yeah, it
relatively
would be, it would be
I'm all for
several
saving the money,
hundred,
but
you
I don't
know.
want to put something in the
Right.
policy that's going to come back and shoot us later on.
Did you get to read them, Don?
No, I didn't.
There's nothing in there.
No, there's not much. I mean, pretty minor stuff. There are a couple of questions I have, though.
Well, let us know what they are.
Well, other than some clarification here, there's some words in here that need to be changed. The one thing that hit me is the secretary of the board is responsible for ensuring the board manual is updated.
Right, that needs to be taken out.
What?
That needs to be taken out. We don't have a
Yeah.
board manual.
Right.
Yeah.
We do have a board orientation manual.
We have the board book that we've
With the board
updated,
book.
but that's it. And then I guess the board governance. is
We have a
what
board
you said,
governance
but,
policy.
Yeah.
The secretary does have some statutory authority.
The
They
secretary
have
will-
stuff, there's some statutory requirements that the secretary's supposed to do. They're supposed to, for the elections, you know, give the position numbers and stuff like that, so I don't know if you want to put that in there, but. those are-
It's in the statute.
If it's already in the statute, there's no harm. I just hate to be in conflict.
And if it's in the statute, there's no harm, so everything that's not in there, you're adding to your responsibilities, and that's where, and if you're not gonna follow them, that's where you run into problems.
That's right.
And it does say we should
Expecting
use
for us to
Robert's
do it.
Rules of Order,
It does.
which is pretty basic. That's what we do.
Okay, so I'll go over some of these with you, Jen, but here's another one. We're gonna limit questions to the public to 3 minutes. Can we do that? Are we gonna do that? Now, I understand in the forum, we had a time frame, but that's not what this is speaking to.
What that gives you is the option to limit, but you don't have to.
Well, the chairman controls the
Chairman
meeting.
controls the meeting.
So they can do whatever.
That's right.
So it's not necessary.
So by stating that we have a limit, you have the opportunity.
This says the comments must, that the public, that we must follow these practices. It says must.
So then that could be changed to may.
It could. Okay. that was
I'd
one.
rather see that taken out myself.
The county uses 3 minutes, and I think that they use that as a guideline, so those that get up there have some idea of what's expected of them. So I think maybe
As a suggestion.
and the maybe might be okay, Chuck, so that people would have some idea, and then at your discretion. But I think that's helpful for the public to know, okay, I can't do a filibuster, I can't be Wayne Morris here, go for 22 hours.
Please not.
We can overall.
Wayne Morris was so last century.
He is a little out.
But you knew who I was talking about.
Okay, another thing I had here is, it says here that the meetings shall be adjourned by a majority vote.
I saw that.
We don't do that,
No.
Okay.
so.
I'm not sure under Robert's rules whether he should or not.
Yeah, you know, does that conflict with Robert's rules?
It's up to
Does
you guys.
anybody
I
know
don't care.
Robert's rules?
But
Yeah.
it
Well,
also
but
says
the
it.
point is, we either do it or we take it out of here.
Yeah, I agree.
So,
I would say keep it as simple as possible.
So we can take that out.
But it has the conflict of interest stuff too, it says you have to abstain from voting. I think there's circumstances where if you have a conflict, you still vote.
We don't.
Break a tie and some of that stuff.
Yeah,
so-
currently we don't abstain from it, we declare.
Right.
We declare.
And that's what usually happens, but that's not what it says.
So we can change that part.
I'm just telling you that I think there's a whole bunch of that in here.
Yeah.
So it I mean, I think you have to, if you're gonna do it, you gotta.
We need to be cleaned up.
Yeah.
Keep it
Well, then
simple.
why don't we put off until we've reviewed this and bring it at another time?
All right.
Is that,
Well, I understood that we had a deadline.
we'll just have to bypass that. Just the-
Okay. Then we better move forward. This is the part I am always interested in, is your employee recognition.
We always have a hard time finding one person that's more unique than another. We have fabulous employees. You know, we have, this last year, we've added clinics, we've had lots of changes. But even though we've had a hard time in one of our areas for many years, we have had somebody who has been with us through the thick and thin and has done an exceptional job. She continues to strive even when it's very difficult, has helped us handle our CPSI installation, our eClinical installation, continues to be an excellent medical assistant, has acted as our acting office manager, and that is in our Alturas clinic, Jolie Cocker. She has really, it's been tough. It is not easy. If you think you've been frustrated, I assure you, our staff equally struggles, but she's done an exceptional job, so we appreciate her.
Thank you. All right, Charlie, CEO report.
Okay. First off, just want to make sure everyone knows that we did complete the financing on October 22 of the refinancing of the $13.3 million. That went through. That was a big deal, and that'll save our district a lot of money. When we changed last year and separated Lakeview Gardens from Lake Health District, Lake Health District has been operating under the DBA of Lake District Hospital and Long-Term Care Facility. It's taken us 10 months. We are now Lake Health District doing business as Lake District Hospital. So the long-term care component has been taken off. That is now official. The CNA class, as Melinda said, is going to start on November 16 and finish the first set December 22. We anticipate having many classes for that. There are other organizations that have expressed an interest in our program. December 1st is when we will go live with a point-and-click program for the long-term care. So that will, we're going to have people going through the process right now, learning how to use the financial component as well as the nursing component. So that will be, that's a big process. The town meeting for the long-term care project, as Melinda said, will be on the, what date is it? It is the 9th, thank you. One of the things that we will be presenting, we have two different plans. One is for the assisted living and the other is for the long-term care, two components. This is going to be filed as a planned, or it has been filed as a planned unit development. We will, once this gets approved, we will then prepare a master plan for our property. It has not been done. In the last 30 years, there's been 20 applications to our planned unit development for this hospital. 20. And if we do a master plan, then we don't have to keep submitting for the plan utility, the PUD, but we would have just land use. Would be a much easier process for the town and for us. So we'll be working on that. Home health and hospice had their survey last month, and they were approved with no deficiencies. So that's really good. So we, just to keep in mind, we've been surveyed as the hospital, the fire marshal is surveyed, long-term care is surveyed, home health has been surveyed, radiology has been surveyed. Trauma has been surveyed. There have been a lot of surveys. I told you that we were redoing our website. The website has taken longer than we anticipated, but it will be expanded to where we have not only the hospital, we have Lakeview Gardens, we have the clinics, and it looks like we aren't the only ones that have suffered from some health issues of staff. Their staff has been unable to get that completed, so it looks like it'll probably be all finished and up and running by December 1st. They committed that they would have it done in September. It's November. So that's been frustrating.
So Lakeview Gardens has a separate website, right? We just have a link to it.
That's correct. Okay. Same thing will be true for the clinics. So that will help keep our identities and to expand our electronic identity and presence. We've had some new hires. You've met Juanita, who's just started. Mira Norris is our new chip coordinator. Mira Norris. She started on Monday. And she's getting acclimated and getting our population health programs going. Emmy Harcourt is the new RARE participant. Remember, RARE is a program through University of Oregon. It's the Resource Assistance for Rural Environments program. She's a RARE participant and is involved with the food bank and supported. The district is not paying for that. It's being paid for largely by the Oregon Food Bank and also with LCRI funds. So she started. At the Rural Health Conference that Jane O'Keefe and I went to, as well as Don, there were a lot of things that were talked about, and I think that you need to understand about some of the issues that are coming up. First off, there is an anticipation that will be 1,700 doctors retiring by 2020 in the state of Oregon. We have 2 medical schools, and we have a shortage of places where residents can practice. So they actually have to leave Oregon to do their residency. This is a big problem. And Moda Health has put up about $500,000, and several other organizations are getting involved, especially the CCOs, to try and figure out how do we get more residents, physicians, not people that live in the community, but physicians to come and rotate into the hospitals or come into the communities. One of the things that clearly has been shown is that if a resident trains in a rural setting, there's a higher chance that they will move to a rural setting. One of the things that this consortium has been formed, is being formed, has asked if you wish to be a participant in the consortium. For $25,000, you can be on the seat at that table. That doesn't guarantee you get a resident. It doesn't mean you have to participate. And if you don't put up money, you don't, that doesn't mean you won't get a resident. But it's an opportunity. They're asking that, and I'd be happy to send information to you about this. I'm not sure it makes sense for us, but it's something that we ought to think about. Make a commitment in November, wouldn't have to put any money up until June. But it's a lot of money to try and get more physician residents, primarily primary care physician residents, to come to rural settings. That's one of the things that's happening. Another program that is being looked at, as you know, I am a part of the Rural Health Reform Initiative, which is the Oregon Hospital Association committee of mostly hospital administrators to look at what to do to improve rural health needs and to address some of the problems that we have. When then Governor Kitzhaber went to Washington and got $1 billion so that we could do, as part of the Affordable Care Act, the CCO rule. We got $1 billion to allow Medicaid to be changed, because Medicaid is a combination program of state and federal dollars. we got that rule, we got about $1 million that was used to look at the issues of rural health. One of the goals, this was 4 years ago, was to reduce the number of hospitals that could be in a cost-based reimbursement. So the Hospital Association took that money and hired experts and has done 2 years' worth of work. Came up with a formula to determine what hospitals could be taken off of cost-based reimbursement. Of the 32 small and critical access hospitals, 7 qualified to come off cost-based reimbursement. Frontier counties, of which Lake County is one, so is Hardy, so is Grant, so is, I forget all the ones that are. But because we are a frontier county, we will never lose our cost-based reimbursement from the state. Unless, of course, state runs out of money. But, so the first part was to take off those 7 hospitals. The next part is, what do we do next? And there are a couple things that the association has been looking at and we have had presentations on. One program has been developed by Mayo Clinic. Mayo Clinic out of Minnesota created a company called Alovent. What Alovent is doing is using what they experienced and taking it to other areas. And so they're considering bringing this to Oregon. What they have found is hospitals that are larger, so they're called prospective payment or PPS hospitals. Those hospitals are paid based on a calculation for each admission, based on the patient's diagnosis and their comorbidities and various factors that go into that. And if the patient is treated in that hospital and then is discharged, if they are readmitted for the same reason within 30 days, that hospital does not get paid for that second admission. So those PPS hospitals are very concerned about those potential patients being readmitted within 30 days. Most of the patients that are being discharged are going to long-term care facilities. And that's where a large portion of those readmissions occur. What Mayo Clinic discovered is that critical access hospitals do a better job through the swing bed program of managing those patients. So the number of readmissions drops precipitously. So what they're suggesting is that we look at, in the state of Oregon, whether or not we could expand the swing bed program in many rural critical access hospitals, and therefore take those patients that would have gone to a long-term care facility and come to the critical access hospitals through the swing bed program. What they have found is if you put that into place, there's a lot of additional resources the critical access hospital has to do. Some of the patients need ventilator, and so you have to hire more respiratory therapists. You may need to have more of a hospitalist program. And so Mayo Clinic has actually put hospitalists in some of the critical access hospitals. It would be roughly about a year to prepare for accepting this change in referral patterns. But it's something that might make sense for us. So I think this is something we want to be talking about. I'll be bringing more information to you. But it's something to be thinking about how it might impact us. Some of the hospitals, if they have, like under 25 beds or under, if they're running a census of 15 to 18 right now, then their capacity to handle extra patients is limited to 25. So they start limiting the number. They're not interested in that. They're more interested in those hospitals that have a lower census on average, that they could raise it to a certain degree and still allow for managed capacity for critical patients or acute patients. Another program that we've looked at is a company called Point B which is looking much more at population health. So you're going to see, we've been talking, that's one of the big things the CHIP program was focusing on. There's more and more demand for hospitals to focus more on population health and trying to address the health of the population before they come into the hospital. So there's going to be more talk about it. Just wanted to give you an idea of some of the issues that we're going to be looking at. Any questions that I could address about that? Do I know why they did that? Well, there's a lot of things. There are.
What was the question?
Why did Moda Health, which is an insurance company, give to
the other way around,
OHSU to Moda Health? There's some mergers and activity going on right now. Moda Health has done an affiliation with Mid-Columbia, which is the hospital in the Downs. It's not considered a critical access hospital. It's about a 40-bed hospital. But creating an alliance is, Mid-Columbia felt that was important for them, and OHSU, same thing. OHSU has formed with Salem Health a program to try and attract commercial business. And so they have formed a separate called Salem Health. It's not the Salem Hospital. So the CEO of Salem Hospital left and is now heading up that in partnership with OHSU. It was just announced this past week that Legacy Health, which has 6 hospitals in basically the Portland area, is in merger discussion with Pacific Source, an insurance company that has 200,000 subscribers, about 40,000 in the Portland area, but also in Idaho, in Washington, and Oregon. So there's some affiliations that are going on. Moda Health, which... Well, there's... when you look at whether or not a hospital or an insurance company is going to go under, there are a lot of factors that play in. Part of it is how much of the market do they control, how much of the market do they want to stay in, and how do they complement each other. Moda Health, which is the old ODS, well, it's still ODS, Oregon Dental Society, that provided dental insurance, has 24 different insurance companies, one of which it owns half of Eastern Oregon CCO. As part of the Eastern Oregon CCO, it anticipated it would get from Medicare a $90 million payment in, as part of the Affordable Care Act that was supposed to come out in September, I believe it was. Medicare came back and said, no, we'll only give you $16 million. It was a huge shortfall. So Oregon Health has said that they might put up something. There's some question about how they're doing. What Moda Health did as part of that response was they stated they will no longer sell insurance in the state of Washington. They're not pulling out of Oregon. So it's getting, what the people at Moda tell me is that they still expect they will get the money from CMS, from Medicare. They're in the middle of a lawsuit with several other health plans and CCOs that were impacted by this. So I think what OHSU is looking to do is try and establish a different kind of partnership with different organizations. Another thing that they have done is St. Charles, Sky Lakes, Asante have joined with Moda Health to sell insurance first to their employees. And they're trying to, like we have with the Teamsters Trust, try and create insurance product that would link them a little bit more together. Part of the reason for that is as you get to a certain size, if you don't have the larger hospitals, and therefore you say you don't have a good heart program, that means you pay a higher amount for buying heart services or cancer services or different kinds of things. So you look for complementary care and for ability to spread risk over a larger portion of the population. Does that answer your question?
Charlie, how is our CCO fiscally as far as, did they lose money last year, make money last year?
Last year, they made a lot of money. Okay. This year, they don't expect to make quite as much money. I did not go to the last board meeting, but they announced that they would be having, one of the problems that they run into is when they submit their rates to the state of Oregon. State of Oregon submits that to Medicare in Washington. So there's an anticipated rate that they're going to get. For year 2015, this is calendar, not fiscal year. Medicare just agreed to a rate for 2015 last month, and that accounts for an increase to each of the hospitals and to the medical groups. Their financial, I'd be happy to provide financials to all of you, because I do get those. But they still continue to be strong. It was Moda Health, not the CCO, that was having a financial issue. There's a lot of moving targets, and I don't mean to make it sound more complicated than it is, but.
Okay. Any other things to report?
That's what I have.
Any other questions? If not, we will take a 10-minute recess. We'll come back and go into an executive session.
Just as one last thing that we didn't announce was the Christmas party. I hope everyone is aware of the Christmas party. It'll be December 11th. Is that the date? December 11th. It'll be at the Elks Club, just as it has been in the past. We will be sending out notices and invitations, but want to make sure you're aware of it.
Oh, and as far as the board's concerned, we're planning a planning meeting on January 12th for the day. Okay. We will come back after 10 minutes and go into executive session under ORS 192-660, 2A personnel, and C medical staff.
And the person